Hear the latest reporting and analysis on the big stories of the day on the Daybreak Insider podcast. It's top-notch reporting from SRN News, along with the sharpest insight from Hugh Hewitt, Mike Gallagher, Dennis Prager, Sebastian Gorka, and the voices of townhall.com. The Daybreak Insider podcast. It's your first look at today's top stories. Available at Apple Podcasts, Spotify, Google, and at SalemPodcastNetwork.com.
Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Yep, here we are again. Glad to have you with us. And by the way, ran into a friend of mine the other day at the store, and he said, you've been doing this vein show. How do you guys talk about veins for an hour? I'm telling you, every time it seems like the hour goes by so fast, we don't get to completely cover the category. There is so much going on in your circulatory system. And Dr. Juleff of Vein Clinics of Hawaii, and once again, remember, they're located on 4 islands, Big Island, Maui, Kauai, and of course here on Oahu, where we record this program for you. And today's program is something that's a carryover that we've talked about before. I've had them. I probably have one right now that can be discussed a little bit. Blood clots. And apparently there's 2 kinds. There's superficial ones and deep ones. And that is the entire extent of my knowledge about them. So it's your turn.
Well, that's a good place to start.
It is.
No question about that. But yeah, with respect to what you said before, the venous system is a very complicated system. Mm-hmm. And I think that we didn't really completely understand that until just recent years. And, for a long time, we sort of discounted the potential effects and the downside to chronic venous insufficiency. But luckily, we're appreciating it now and treating it much more aggressively.
Well, let me tell you what I've heard since we started doing the show, and that was people saying the same thing. And until it mimics or sort of looks like one of the symptoms they have, people, and then as soon as it zeroes in on one, says throbbing or pain or biting, or then they say, hey, wait a minute, that might be me. And I'm thinking that, if you send, this is going to be, you're going to think this is a joke. Talking to a friend of mine years ago, he's a dentist, and his brother was an orthodontist. And orthodontists usually get patients referred to them by dentists. But they never say that your teeth are perfect. So anybody that goes into the orthodontist is going to have something that can be fixed.
Right.
Is that the same with our circulatory system?
Well, I hope not. I mean, I guess you have to draw the line at the point where you have to decide whether something's significant or not.
Sure.
Do we all have probably somewhat dysfunctional veins in one way or another in some part of our body throughout our entire life? Yeah, definitely. Absolutely. Yeah. I mean, just looking at the people or the demographic of patients that have obviously significant venous disease, it's a huge part of the population, 50%.
Yeah, and that's why I was asking, because we have a lot of stuff to talk about today, but recently in the news was a couple coming here to Hawaii from the mainland on an airplane, and when the plane touched down, the woman realized that her husband was still in the lavatory and went in to get them, and he had died in there, 74-year-old man. And, of course, all the release that came out was no foul play, So that means it could be a myriad of things. But apparently, according to the wife, his heart was okay and not bad. So we often talk about what happens if you are especially older and travel and have one of these clots become serious.
Right.
They can be life-threatening, right?
Oh, absolutely. Yeah. And they're definitely fatal, and it probably happens more often than we know. But that gentleman, he was a perfect setup for having developed a blood clot in his leg, and then it traveled to his lungs, and people instantly die. Okay. So yeah, there are a myriad of things that he could have died from. Probably the most likely would be a PE, pulmonary embolism. Yeah,
and by the way, we're not doing this to scare you all. There are lots and lots of different kinds of clots that we're going to talk about. But in the introduction, to me, it says superficial and deep. So I'm guessing that some blood clots are right on the top of your skin. You can see them.
You can.
I've had some of those removed.
Yes.
Yeah.
There's two systems of veins in the legs, and we call those the superficial system and the deep venous system. So typically, it's sort of an anatomic separation there, and blood clots can form in either the superficial or the deep. And then, so we have that classification. And then also when we're trying to decide how threatening a blood clot might be, we also have to consider anatomic levels. Distal, or, we refer to below the knee sort of clots as distal clots. As you come up, it's more proximal. And as you come up in the venous system, when a clot is present, for instance, in the upper leg or in the pelvis, it becomes a much more concerning situation, because those clots are the ones that break loose and kill people on airplanes, like you just mentioned.
Can part of those clots be? Let's say that if a female is pregnant, are they more likely to get a clot in that area because of changes in their pelvis?
The pregnancy is definitely a risk factor for DVT. It can be pelvic or in the leg, but a pregnant woman, there's a lot of new things happening in their pelvis that can impact vein function. And then a lot of people say, well, can you get blood clots in your arms? And you can for sure. They are a little less threatening. They rarely become a major problem. Sometimes we treat them with blood thinners. Sometimes we don't. But can you get blood clots in arms? Yeah, you can.
What do blood clots come from? What causes them?
There's a number of different things. But the number one thing that comes to mind is having the patient having a sedentary period, just like our gentleman on the airplane. People who are on long plane rides, long car rides, on a train or whatever it is. If you're just sitting for a long period of time, not ambulating, not moving your legs, that's your perfect setup for a DVT.
It's ironic because we've talked about that on other programs, and then these days a lot of us travel great distances. Big fast airplanes can take you all the way to New York from Hawaii.
Right.
And it used to be, as soon as the plane took off, some nice captain's voice would come, okay, folks, this is going to be an 8-hour trip. Please feel free to wander around the cabin and make friends.
Yeah.
That's not the case anymore, is it?
They don't encourage that anymore because there's so many people on planes these days. But, and that's what you have to do. You have to be concerned about that on long plane rides and get up and, despite what they try to, make you do, walk a little bit. But the other thing is dehydration. And, that happens to us on airplanes and in long travel sort of activities. Also, you're sitting in one place, you're not drinking enough fluid, and it's easy to get dehydrated. During illness, again, as another category of people who are at risk for DVT, when we get sick, we don't drink enough, we get dehydrated, and that's another period of time when you could be a setup for blood clot.
And by the way, when you're talking about getting hydrated, it's like water, right? I mean, from what I understand, somebody says, well, I never get dehydrated because I sip wine all the way on the plane.
Yeah.
Isn't that exactly not very good for you?
Yeah, that's what you
might make you feel kind of happy, but it's not doing you any good, is it?
Yeah, alcohol in general is what we refer to as a diuretic. It makes your body get rid of fluid, so you're defeating the purpose of the fluid intake. So, can you have a drink on a plane? Yeah, you can, but at the same time, you need to be drinking other fluids too.
We mentioned in other programs, and I'm sure we're going to cover that today, not all blood clots break apart and become life-threatening.
No.
But what one have to wonder, if you've had one in there for a long time, are there other concerns that it could be more than just a blood clot? I mean, can it be cancerous? Can it be malignant? I mean, if it's stopped in there and one of those veins is not moving anywhere?
That's a good question. Could the process itself be malignant? No, but people with cancer, people with malignancy, are another group of people who are at a higher risk for developing a DVT, and that has to do with just the chemical abnormalities that are occurring in the body because of that malignancy. But yes, we always have to be concerned, especially people coming into the hospital that are being treated for malignancy, that we're making sure that we're addressing the prophylaxis for DVT.
We do a program with Dr. Campbell, and he talks about being able to, regenerate or rehydrate somebody. So if somebody does, and I saw this in our notes, what are the best ways to maybe get back in the hydrated shape? How do you know? First of all, many of us don't know what's coming. My wife always tells me, your voice is very hoarse. You must need a lot of water, which is true.
Yeah.
Right?
Yeah.
So are there ways to do that are just totally natural? I guess just drink water. Yeah,
I think that the body, being the amazing machine that it is, it tells us when we need to have more hydration, and that's called thirst. And you just have to be sensitive to that feeling and respond to it when you need to. And I think there is some we've talked also before about being able to drink too much water. Mm-hmm. Yeah, there is a situation where you can, but that's hard to get to. And I think probably in general we all need to drink probably more fluid than what we are.
Okay, now, how does one find out about clots? I mean, you said earlier we have these two systems, superficial and deep. So superficial, you can see them. Aren't the real bad ones the ones that you can't see?
Well, yeah, because sometimes you don't know. Most of the time, people have symptoms, but superficial blood clots. Often you can see them and feel them, and they become very inflamed. But we also typically will do an ultrasound for that in addition. Mm-hmm. And often we're making sure that the patient doesn't also have a deep venous blood clot. Mm-hmm. But some of the other reasons why people, we sort of touched on some of these, but trauma, obesity, pregnancy, other illnesses like inflammatory bowel disease, Crohn's disease. Many people out there have Crohn's. Medications like birth control pills.
Sure, I was going to ask about that.
And and then sometimes there's no apparent cause.
Okay, now I know that I think when we first met, we did a little mention on clots. We do it in every show, but and we need to. But I was asking, and always somebody wants to know, okay, well, what pills do I take? And I remember that there are some things that you can take. There's some things that help you get rid of a small clot, and you can explain what they are. But other than that, if you have a pretty big blood clot, that you probably have to go in there and get it.
Yeah, well, yes and no. Sometimes, unfortunately, with blood clots in the veins, it's very difficult to surgically go in and get it.
Okay.
Now, has that been done in the past? Oh, yeah, definitely. But the ultimate benefit from those procedures was turned out to be suboptimal. But we treat almost all deep venous blood clots with blood thinners. Occasionally, we might go in. We might do something invasive to dissolve the blood clot. Mm-hmm. That's not a routine sort of thing.
I get it. Okay.
And and there's only a handful of people that may benefit from that.
When you go in to address them, I'm just curious about how if they can form in a perfectly good vein, or if they have to have something going on there. I mean, I imagine all this blood's flying around, and somehow, some way, a piece of it sticks, and then gets bigger and bigger, like a grain of sand in a pearl. Mm-hmm. But pretty soon, the big thing comes out of a little thing.
That does happen. Mm-hmm. But can blood clot form in perfectly normal vein? Yes, it can. Yeah. There's no question about that.
Is that impurities in the blood? Things in the blood that don't belong there?
The things that we kind of listed. Having just being sedentary for a 4 or 5 hour period. Your blood, basically the blood stops moving. It lacks flow. And when the blood stops moving, then it becomes more coagulable, and then a blood clot forms. Now, the other side of that is, do we see blood clot in abnormal veins? Yeah, definitely.
I would imagine. Yeah.
And many of the superficial venous thrombosis, something that we call SVT, often those arise from abnormal veins, typically varicose veins when they're in the legs. Superficial venous thrombosis is not an uncommon thing. It affects 125,000 people in the U.S. Annually. It affects women a little more than men. And again, it's the most common feature is the presence of varicose veins, especially if we're talking about an SVT in the leg.
Okay, now, do you ever get clots in what you call the spider veins? In other words, the spider veins, which are a cosmetic decision somebody makes, do they clot?
They're
pretty little,
yeah,
aren't
they can, but they're so tiny, it's really inconsequential. It probably is, if a little bit of thrombus forms in a tiny vein like that, especially since it's so superficial, it can lead to additional, cosmetic sort of problems. But is it, from a physiologic basis, is it in any way consequential? No.
Okay, and by the way, everything that we do on the show, you can check out at veinclinicshawaii.com. Veinclinicshawaii.com. There's a great contact us button if you want to hear something on the program. Sometimes we do a program, we just call it Mailbag, where we dive into stuff that you want to know about. But we have sort of a path to go down. Today's talking about the different kinds of blood clots. And I know because I'm working on, it's just coincidence, they're working on one on me right now. And these are usually, I want to ask for a minute because I know mine is in the little deeper vein. So what would be some of the reasons somebody would think, I better call doc. I better find out if I've got a clot. Do they have symptoms?
The most common symptoms for DVT would be pain and swelling.
Okay.
Tenderness, infrequently you can have a little bit of redness or skin discoloration. But those are the primary symptoms. And I think most of the time people are aware of that. I think that some people, don't address it or respond to those symptoms. But I think if you have a significant kind of deep venous thrombosis, typically there's going to be some symptoms, yes.
Yeah, I wondered about that because I was trying to think before we discovered what's going on with me, which just, here's what happened to me. A couple of weeks ago, I hurt myself, and I was going about, getting it looked at, and I talked to Dr. Juleff. He said, why don't we do an ultrasound and to see where you are, because it had been a couple of years since I've had it. And I think it reminded me, and it should remind our listeners, that a venous disease is usually not made to go away. If you have venous disease, you're going to have to manage it for a long time. So there must be a period of time when you can diagnose me, which you've just done, and found this clot, and we deal with the clot, and then you can see, are there any more, or are there any is there any particular area that might look like we have to keep an eye on it?
Yes.
Yeah.
Well, in your case, there's a few things there. Yeah. But in your situation was again a very typical scenario. You had some other aches and pains. Right. You sort of had to become sedentary for a while, and I think that probably played a role in you developing the blood clot that you did. Luckily,
so they can come up quickly.
Oh yeah, very quick. Yeah. Again, take the example of the gentleman on the airplane. He probably didn't get on the airplane with that blood clot.
Yeah, and I wanted to ask you that because I'm wondering if there are times when you have to counsel a patient that's saying, oh, doc, can we come in and do this because I'm going to Paris next week? Are there some times when you say, it may not be a good idea? In other words, once you're up in that airplane, anything can happen, right?
Yeah. Well, there are situations where you might have to advise people against long distance travel, but most of the time it can be managed in one way or another. Now, which kind of gets back to the question that you asked before: does DVT happen in abnormal veins or normal veins? It can happen in normal veins, but people with chronic venous insufficiency are a little more at risk for developing a DVT. So if people are concerned as to whether they might have vein disease, then that's a good answer to be, or a good question to be answered before they do long distance travel, so that they can do enough to protect themselves.
Just out of curiosity, because it seems like television is our launch pad for self-diagnosis and hypochondria, and I notice there's a lot more on veins than there used to be. And I think in many cases, this is probably good, because if people can recognize a symptom by looking at one of those ads, they might just put in the back of their think bank, I got to look at it. There's that PAD. Is that and the DVT the two?
Well, PAD is peripheral arterial disease.
Yeah.
So that when we talk about artery problems, we call it PAD. When we talk about venous problems, we call it chronic venous insufficiency.
See, what I'm thinking is the medicine company trying to cover both ends, because they probably make a medicine for this and a medicine for that.
Yeah.
But does it help? Have you noticed, for instance, you have 4 offices here in Hawaii, an increase in inquiries based on these things that they see, because they barrage you on TV. They're just hitting them over and over again.
Yeah, sure. Yeah, I think in some ways that's good, in some ways it's not good, but anything that's going to cause the people to understand those types of things better, it's a good thing. But the other issue with superficial venous thrombosis, although it's something that we don't get as concerned about with compared to DVT, deep venous thrombosis, if people have recurrent SVT, then we begin to think that there's something else going on here than just simple, superficial clots. And one of the big things there is malignancy. Getting back to that. If people, or if a person were to have 2 or 3 episodes of SVT, they may not have had any symptoms referable to a malignancy that they may have developed. But at that point, we might go looking for it. So,
the reason I ask that, and I think that's a great point, is that no question we're living longer. And no question we like to do things and move around. And so what may not have developed in as many people is developing now, meaning that when you say, okay, when you have these little things going on, you got to look at other things. So isn't that part of the relationship between the doc and the patient, And I noticed you have a very thorough questionnaire in your office to find out what brought you in here, what are you feeling. How does that help you when you start working with somebody?
Well, it helps us a lot because it kind of pinpoints or it directs our evaluation. Especially for physicians that are covering a much more broader spectrum of disease processes. What we do is nice because it's a fairly discrete niche of part of vascular surgery. But we consider all of that. The complaints that they're having. What has happened to them in the past? Have they been treated before? Things like, what medications are they on? Yeah. Are they allergic to medication? Do they have a family history of whatever it is we're looking at? So, all of that is very, very important.
I'm getting really good vibes, and I'm sure you are too now, out of the media and other suppliers, because they're saying, it's combination. A lot of people are taking a lot of things, and they don't even really know. I read of one guy that got in big trouble because he was heavily supplementing himself, and then somebody said, "Have you tried this?" "Oh, no, I'll take some of that." And pretty soon the guy's taking like 30 things and didn't need half of them.
Right.
And so I'm guessing that can be sort of an issue too.
Yeah, that's the other side of the coin there. So. So how what does an SVT look like? And you sort of alluded to it before. You can see them superficially most of the time, and the skin can become reddened. It can be fairly tender. And it's a firm area, and again, often it's in an area where the patient recognized as an area where they previously had varicose veins.
Can there be a trauma? Because I knew playing football that I was always heavily bruised on the thigh, because thigh pads were part of your uniform, but they're sticky. They got in the way. A lot of us took them out, and so when you get hit, some of those things lasted a long time. Some of them never went away. And I'm just wondering if that is permanently damaged superficial veins.
Trauma can play a role, definitely. So you have to kind of decide exactly what happened there. But repeated injury in one area, I'm sure it had an effect on superficial veins. Did it lead to SVT at that time? No, maybe not. Yeah. But did it affect the overall appearance of the superficial veins? Yeah, sure.
Yeah, because isn't a bruise just a bunch of blood that shouldn't be where it is?
Yeah.
And so where does that blood come from? Come from an artery or vein?
Well, it's broken veins that superficially. Usually it's a vein thing. But absolutely. So, in that situation, there is a traumatic event happening to those very superficial veins.
Okay, well, I had this one, and I think, and I had it for a long time, and it looked sort of like a spider's nest, a big one.
Yeah.
And it was about maybe bread plate size on top of my thigh. And it wasn't, not solid, but, it was all there. It's totally gone. I can't see any part of it anymore. But that doesn't mean that it couldn't happen again, does it?
No, not at all.
I wrote that one off to trauma. I thought that was an injury. Then I got to ask you another thing. A friend of mine who's a baseball player got hit on the side of the knee in high school, and it's as big as a silver dollar, and it's been there his whole life. And a couple of times it got cut by, just banging it against something.
Yeah.
Can these be a problem when they just sit there year after year? Or shouldn't somebody say, I don't think I should have that on my leg?
Yeah, typically it's not in and of itself going to create a problem. And we do hear that story all the time where, people come in with superficial things that they don't like from an aesthetic standpoint. And they say, oh, yeah, I played volleyball and I was always landing on that part of my leg, or baseball, or any so many sports where you might be repeatedly injured in the leg. And so sometimes it's due to that trauma in the past. Sometimes it's just coincidental. Because, spider veins can show up anywhere on our legs, whether you had trauma there or not. So it's hard to sort it out sometimes.
And what I was pointing at here, gang, I think awareness is 90% of this. And it's probably, if you are examining your little bumps and lumps right now as you're listening, which is a pretty normal thing, that doesn't mean that you are a hospital case. There's lots and lots of times when it's an election, isn't it, Dr. Juleff, where people just decide, well, I thank you for letting me know about that, but since it's not really going to cause me any trouble, I might want to deal with this cosmetically, but not right now.
Oh, yeah. Absolutely.
Especially guys.
Yeah. And even some people with limited kind of venous insufficiency, problems with the deeper veins, not just spider veins.
Yeah, but, that's what I want to talk about.
There's people out there that have a modicum of venous reflux that doesn't really need to be addressed immediately. So we just follow those people.
Yeah, that's what I was thinking. And when I had the ultrasound the other day with one of Dr. Juleff's practitioners, who's really, really great, and we learned a little bit about anybody can, get a machine, but to operate it, the operator's extremely important to that. And I noticed that he said, okay, you can see this here. This is a little reflux, but it's not much. In other words, you're actually able, with this device, to measure the amount of reflux.
Right.
That's fascinating, isn't it?
Oh, yeah. The ultrasound technology has made our job a lot easier, but you're absolutely right about the technician. It is so operator dependent, and you really need to have somebody who is high quality to be able to give you the answers you need. So how do we treat SVT?
Yeah, exactly.
Well, most of the time we treat it just locally and symptomatically. So what do I mean by that? Well, we start people on anti-inflammatory medications because it's mainly an inflammatory event or an inflammatory situation. Sometimes people are evaluated for SVT and they get treated as if it were an infection because it's red and it's firm, it's tender.
That just means it's going to take a lot of time before you find out what's really going on.
Yeah. So in most of the time, it's not an infection. Now, can a superficial superficial venous thrombosis become infected? Yeah, that it can.
Does it need to be abraded or open somehow to have that happen?
If it's infected and it's not responding to antibiotics, then yes, sometimes we do have to open it. That can be a little more complicated situation, but typically we start anti-inflammatory medications. We usually recommend warm, moist compresses to that area, and then compression stockings, and typically it will go away. Now, the SVTs in general, again, as I mentioned before, we don't think of them as being anywhere near as threatening as DVT. Yeah. There are, however, sometimes that we do start the patient on blood thinners, which is what we do for DVT. But so if we when we evaluate the superficial clot, if it is in a particular location, depending on how extensive it is, some of those people will get blood thinners, but that's the minority.
Okay, my thought was that, let's say that you take the blood thinner. Does that mean the blood is now moving faster through your system?
No, it's just that the blood thinner is going to not allow the blood clot to extend.
I get it.
Basically,
all right. So
get bigger.
Yeah,
we don't want it to get bigger.
Yeah. As a matter of fact, would it be sometimes recommended before you can do surgery or get somebody squared away to do that just because they've got a lot of stuff going on there? They just need to thin things out. What are the consequences if you don't?
If you don't do
in other words, if somebody says, I don't want blood thinners,
Well, I think you have to consider how threatening that blood clot is. I mean, can we treat some people that may in other situations be anticoagulated, and we just make the decision because the patient doesn't want to be on those kind of medications? Yeah, but if it's really a blood clot that we feel is very threatening and especially potentially fatal. Then we try to talk the patient into being treated the way we think that they should be.
I know that we could do a whole hour on this next sentence I'm going to ask you, and that is, I've seen a couple of TV shows lately where there seems to be major disagreements going on about vaccinations, about vaccines and things, where there's a lot of people saying, I don't want to put this into my or my child's body, but there also comes a time when they're saying, if you want to come into this country or if you want to leave this country, you have to do this. Are there any concerns about that sort of condition going on inside people's veins?
Not really. There isn't a corollary to that. Yeah. You mean with respect to whether that patient is going to be treated or not? Yeah. Similar to whether a child is going to be vaccinated or not? Not really.
Yeah, not really. I was just curious about that.
The vaccination thing now, you're right, it's becoming a little more critical because we're seeing the resurgence of
things like
diseases.
measles, for instance.
Measles. Yeah. Because there's so many people, not only from other countries coming here that aren't vaccinated, but also so many, people in this country that have chosen to not vaccinate their kids, and we're seeing the repercussions of that now.
Yeah, which is an awful thing. And in hindsight, it's too bad. But I get it. Maybe there's some people that don't react very well to the vaccines, and once that word gets out, if they say possible this and possible that, say, well, I'm not going to give my kid that. I'm not going to take a chance.
Yeah.
Okay, but okay. When we made the transition a little bit about how you're treating these surface, blood clots.
Yeah.
But let's go in a little bit inside. First of all, I'm guessing that you're going to say the best way to detect them is with a good ultrasound examination.
Yes.
Yeah. That charts them out.
Yeah, no matter which one we're talking about, DVT or SVT, we're going to do an ultrasound. And, for people who we suspect of having a deep vein thrombosis, we want to rule it out and make sure they don't have it. But when they do have it, then we need to define where it is and, how anatomically threatening is it, et cetera, and that will impact our treatment. But patients with SVT, we are not as much trying to define the anatomy of the blood clot itself.
Okay.
We're making sure that they don't have a deep venous thrombosis,
Gotcha.
because sometimes a superficial blood clot is a symptom of a
something right behind it.
Right, a DVT. So again, we would treat those people very differently if we find that.
One thing that always amazes me is that maybe how many of these can exist. Let's say that somebody is in not very good shape. Is it possible to have lots and lots of clots?
Well, people do have recurrent blood clots, but typically when a clot forms, it forms as a single entity, and it may be. I think we're more concerned about the extensiveness of a blood clot as opposed to, how many are there?
Oh, you know what? I'm so glad you said that, because I remember in the previous program we talked about maybe people don't really understand how sizable these clots can be. In other words, you think of a clot like when you ding your finger and you see this little thing on top of there.
Right.
But from what I've seen in your office and at veinclinicsofhawaii.com is these things can be like a couple of feet long.
Yeah. Well, they can be long, and they can be, as far as how big around they are, they could be as big as the vein that they're in. And sometimes people develop, if they're developing blood clots in the upper leg and pelvis, those more dangerous ones, those veins can be pretty big.
Yeah. I'm fascinated by that. I saw a diagram, and by the way, if you want to hear something on the program, what we'd like you to do is go to veinclinicsofhawaii.com and just hit the contact us button or send us something that you'd like to learn about, because some of the shows that we do are they're the mailbag shows. But this one here, it seems to be something that I don't think there's too many times we can run this up the flagpole to talk about the different kinds of clots there are, because I think that outside of discomfort and maybe appearance, the clots really get somebody's attention if once they are prone to have them, to stay kind of on it. I know that I am. Mm-hmm. I'm going to schedule every 6 months or every year an ultrasound for sure.
Yeah. Once you have a blood clot, that immediately puts you in a higher risk for not having another blood clot. So it's something that really does need to be looked at periodically. And also, is that clot associated with venous insufficiency, venous reflux? Does that patient, just because they have a blood clot doesn't mean they have venous insufficiency. But many people with blood clots have venous insufficiency. And we need to define that too, and we'll decide whether it should be treated or not. But, getting back to deep venous thrombosis, how is it different than SVT? Well, it's a little more threatening. There's no question about that. And why are we concerned about that? Well, one of the big things is something that we've talked about already, and that's the possibility of pulmonary embolism.
Yeah, and that is, explain to people, I guess you know what pulmonary is. It's sort of your lungs and your breathing. But maybe people don't understand why that road exists. In other words, this blood that's coming up through your veins gets handled. Mm-hmm. And if you have what you call, when you say this PE, pulmonary embolism, isn't that a piece that's actually come off a vein and a clot and lodged somewhere else where it shouldn't be?
Right. Yeah. The some blood clots in our legs, periodically, the upper part of it will break loose and start to travel, and that situation is much more likely in the clots that we see in the upper leg and pelvis. Our veins, all of the venous system are the highways of blood back to the heart. Mm-hmm. So, this blood clot breaks loose, starts to travel through the venous system, goes back up into the heart. Now, usually that clot is not going to affect the heart. But as blood comes back, through veins back to the heart, it's on its way to the lungs.
I was going to say, now lungs are the next stop along the line,
next
right?
Stop, yeah. So that's what happens. These clots can kind of wind their way through the heart and then boom out into the lungs. And if they are big enough, like we keep saying, they can be fatal.
Yeah. What about when you hear, when somebody's got a vein or a blood clot in their head? Mm-hmm. Obviously, there's a lot of stuff going on in this brain. I would imagine that something would be way more life-threatening if it got to that stage.
Yeah. The blood clots that you typically hear of people talking about in the brain are more having to do with the arterial system.
Mm-hmm.
But not that, I mean, and that's going to create problems too. There's no question about it, but it's a little different process than what we're talking about. So we get concerned about DVT causing pulmonary embolism. The other thing is that, and again, this depends on how extensive the initial clot was, but it is going to damage the vein functionally. Mm-hmm. So, the deep veins have one-way valves in them, just like the superficial venous system, and those little one-way valves are crucial for normal vein function, for blood to keep moving upward. And when a clot forms, it can cause little fibrotic and basically scars down these little valve leaflets and can create damage to the function of that vein. And that venous insufficiency that we see then over a long period of time is something that we call post-thrombotic syndrome, where a thrombus has led to damage to a vein and then the repercussions that come eventually.
Let's talk for a moment about what happens when you sit down with a patient and make these discoveries where there are some issues, how you map out a plan or a program as to how much you can do at any one time, or how many can you multitask and get rid of some spider legs at the same time you get rid of this and that. I know it's not as time is very precious, but I also think that once somebody finds out they have something, they would say, let's get on with this. I want this now.
Sure. Unfortunately, the insurance system right now kind of gets in the way sometimes of us taking care of people in a very efficient fashion. When we find these problems, it's better for the patient to have them repaired. The longer the process goes on, the more ultimate damage there is going to be to especially the skin of the lower leg and swelling and all these
Yeah, and that's why we'll differentiate right now with some of the symptoms. Some of the usual symptoms that cause this pain and swelling. It doesn't automatically mean that you've got a blood clot.
No.
But to get a blood clot, it probably has to go through that stage.
Mm-hmm.
I mean, we don't want everybody to worry. As a matter of fact, when we talked earlier in the program, even though this is very, very damaging to some people, it is not as common as other parts of the venous disease, right?
Yeah, right. Yeah. Sure.
Okay, so that being said, how do you do that? The usual symptoms are pain and swelling. These are your good, your good benchmarks that you got some issue going on there. But what about other things?
Pain, swelling, redness.
You mentioned discoloring.
Yeah, discoloration.
Sunburn looking.
Yeah. Sometimes, not very often, but sometimes you can actually feel the vein that has a clot.
Really?
In it.
That must be fascinating.
And a lot depends, with respect to symptoms, a lot depends on what level the clot is at. So, we see people periodically that have blood clots in what we would refer to as the deep venous system, in the calf and lower leg, and they really have minimal symptoms. So the higher up the clot, the higher up in the limb that the clot occurs, the more symptoms you're going to have. And the basic reason for that is because the higher up it goes and the clot forms, the more it's impinging or affecting flow.
Okay, so what do we do once this has been discovered, as far as what's the way that you either surgically or medically get at this thing to get it removed? Because, we've talked to a lot of people over the show before, and, that back in the days, having these kind of conditions was a pretty miserable trip to the doctor and getting your legs cut open and all of that stuff. I think now with just being in your office and seeing all the facilities, that a patient that had one 40 years ago, if they're back at it, they're going to be pretty pleasantly surprised that the treatment is a little less invasive and certainly less painful as it used to be.
Yeah, absolutely.
Okay, so what do you do with, now we're talking deep VT, right?
Yes.
And not pulmonary embolism. I don't know, how to do that, a pulmonologist or something. Who deals with that?
Well, we treat that.
Yeah.
We treat it. But so yeah, what is the treatment? Well,
I'm guessing that there are several, depending on which clot in which veins that we're talking about. But if I mentioned before the inside, the ones that you can't see that you found. Now that you found it on ultrasound, and you mentioned earlier that there were some things that you could do, some chemicals and some things. But if it's a stubborn one, now what?
Well, it kind of goes back again to how extensive this blood clot is, and in which system it's in. Mm-hmm. Usually, we don't treat people with superficial clots with anticoagulation. Sometimes we do, but that's a small number of those patients. Virtually all patients with deep venous thrombosis should have some form of anticoagulation. And the period of time that they stay on the anticoagulation is sort of dependent on the basic scenario of their blood clot, why it happened, how extensive is it, and is pulmonary embolism a part of it?
Yeah.
So typically people are on anticoagulation at least for 3 to 6 months. And the type of medication that we use varies a little bit, but we used to treat everybody with Coumadin.
Yeah, I remember seeing that a lot.
Yeah, which is rat poison.
Yeah,
and but
I'm glad I learned about that later.
Yeah, but people were treated very well with that. But there's some newer medications that are a little easier to administer. Don't require all of the blood tests that we had to do with Coumadin, and accomplishes the same thing.
I do notice, and we mentioned this earlier, and I think this is very important, gang, and this should be just a general practice, as Dr. Juleff has told us, that a lot of us go to a specialty doctor for a certain thing, like a vein problem. But, you also go in a doctor for a kidney problem, and you go into your other doctor because you got whooping cough. And you got fistfuls of stuff. Almost every place I've been, particularly your office, please write this list of whatever medications you are taking and whatever medications you may be allergic to.
Right. Yeah, it's important to know that. We need to know that not only when we're considering whatever it is that we're treating the patient for, but also the medications that we might be prescribing.
I was at a friend's house the other day and helping him install something in his bathroom. And the medicine chest was open. It looked like an apothecary shop. I couldn't believe it. Anybody would have that much stuff. But so I do know that people are instant gratification. Isn't that sort of nice to know now that in your practice, these things are done quicker, less invasively? You walk in, you get a treatment, and you walk out. Mm-hmm. That's fascinating.
Yeah. It really has been a very nice change for not only us as providers treating these problems, but also for the patients. It's gotten so much easier for them to be treated for vein disease as opposed to 20 years ago.
Okay, I'm also looking in the road map on my leg, and I'm thinking, how long does it take for one of these things? Let's say that you have a blood clot just below your knee, or maybe just above your knee. How long does it take that rascal to go up the system if it breaks loose?
Well, if it breaks loose, it's going to happen pretty quick.
Really?
Yeah.
What's pretty quick?
Oh, a couple minutes.
Oh my! I thought you were going to tell me a week.
Yeah, no.
Pretty quick.
Again, the scenario of the gentleman on the airplane. Mm-hmm. I would guess that he probably did not get on that plane with a blood clot. If he had a blood clot, which I think he may have, he didn't get on the plane with a blood clot.
Certainly a candidate, though, right? I mean, at that age, and maybe not being in 100% shape, certainly being a candidate for that.
He could have, definitely. But the point at which it broke loose was when he was on the airplane, and it moves quickly, and its effects are sudden, just like we saw.
There are some that have other diseases, and we've mentioned real quickly. Maybe we can just concentrate on this one. Say something like Crohn's disease or diarrhea or constipation, where somebody has to really push, to make a bodily function occur. Can there be damage when that happens in your circulatory system?
Is it going to damage veins in a way that will ultimately lead to vein disease? No. However, it can be a part of pulmonary embolism.
Yeah, I was going to say that because
if somebody has a DVT in the upper leg of pelvis, and they need to strain, that can be the cause for a piece of it to break loose and form a pulmonary embolism. And we hear that scenario not uncommonly.
Yeah, I was wondering about that because I do know that when people travel sometimes, especially if they're in faraway places and eating different foods and doing different things and having jet lag here and there, that their system probably is not up to 100%. So they would be susceptible for something happening rather quickly.
Mm-hmm. Yeah. So the other way that we sometimes treat DVT, although this is also not all that common, and there's some controversy as to the people that would benefit from this as opposed to not benefit in the long run, is something called thrombolytic therapy. And thrombolytic therapy basically is a clot buster. It's a medication that will actually dissolve clot. So the way that happens is that we have to insert a little catheter into the vein and embed it in the clot and infuse this medication into the clot, and often we see very good clearing of that blood clot.
Does that thing stay in there?
No. The catheter stays in for a short period of time.
I just wanted to know that, just in case.
And then it comes out.
Yeah. Not a parting gift.
No. So, so in the results, some of the results are very, very good. So again, but there's it's an invasive process. There is some risk because you're not only anticoagulating the blood, but you're introducing a medication that is actually dissolving clot, and it can lead to spontaneous bleeding in other places of the body. So there's some risk to that procedure itself, but sometimes it can be beneficial.
Yeah, and I'm guessing, I already know this, folks, if Dr. Juleff's office is on the Big Island, Kauai, Maui, here on Oahu, that if you are have been treated for whatever, you're given a sheet of, some instructions on what's going to happen, what other things you should keep an eye on. And so when something is done, being observant of how you feel for the next few days is important.
Mm-hmm.
Yeah.
Right.
Especially if you're dealing with one of these things that happens when you're traveling. And I do know that you and others here in Hawaii will get special calls from sometimes where somebody has an issue where they really get, they are acting like they got some sort of a blood clot that has to be dealt with.
Mm-hmm. Yeah.
Does it help? I mean, do you sometimes maybe even give somebody a lead when they're going somewhere? If this happens, here's a little travel sheet. If you notice this, don't do that.
Yeah. Well, we do that. Sure. And I mean, we talked to almost all of our patients about travel and what they should do to avoid, having problems while they are traveling. And sometimes we have to alter the plans of the patient. It wasn't too long ago that we saw a patient who had a fairly extensive DVT, didn't have a lot of symptoms, and he was planning on getting on a plane like the next day or two. Yeah. And
maybe not a good idea.
No, in that situation we had to say no. We need to start treatment. And
I know what I'm going to do. If I ever have a long trip, I'm coming out of your place and say, okay, do a ultrasound. Yeah. If there's something in there, I'm not going.
Yeah.
But I still think that people should very well be aware. We've not avoided it, but you cannot just cruise with one of these things. I mean, it can be a problem.
Yeah.
Only a small percentage of us get that, but if you're one of those, it's not a very fun thing.
No, it's highly fatal.
So there you go. I hope you learned a little bit on what to do about this. When you're treating somebody for just a regular varicose vein treatment and you notice something like that, how do you deal with it? Real quickly, do you just keep an eye on it, or is every clot that you find out got to go? Do they all have to be done immediately?
No, typically, if we were evaluating somebody for varicose veins and venous insufficiency, and we found a deep venous thrombosis that we felt was relatively recent and untreated, we would certainly treat them for the DVT first before we would do anything else.
Gotcha. Okay, my friends, that's going to do it up for this episode of the Vein Clinics of Hawaii show. If you got a comment or a question, or if you'd like to hear something on the program, please contact us at the office. You go to the web, veinclinicsofhawaii.com, or you can drop me a line at themikebuckshow@gmail.com, and I will make sure that your requests get aired on one of our shows. We call those the mailbag shows, and we'll have one of them pretty soon. Thanks for being here. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.
Let me be straight with you. This is a radio commercial for 3 Small Business Insurance. The policy has no fine print. It's clear what's covered. So while you can't see the following scene, just know that this pet store is protected by 3.
Joe, did you leave the snake tank open?
Look, I don't want to point fingers, but yes.
It's biting me! Sorry, sir. I'm calling my lawyer.
They're going to need some help with this mess. Luckily, they have 3. No fine print, just exceptional coverage. 3 is a product of Berkshire Hathaway Direct Insurance Company. 3. No nonsense, just common sense.